Some of the things that have been going on in immune research now, for example, is the molecular mimicry theory, and that is that the immune system, while it's pretty good, it sometimes misreads things. And we have a theory now, and this is undergoing extensive research, that your immune system might be misreading the herpes viruses and developing autoantibodies, resulting in Sjogren's syndrome, Raynaud's phenomenon, and even systemic lupus. And I'll go into that in a bit more detail later. The endocrine research has been somewhat soft. The patients do have abnormalities of antidiuretic hormone and generally mild hypocortisolism. And many studies have looked at that. It's not as dramatic as we had once hoped. And I'll point out that hypocortisolism is the exact reverse of the finding that you find in depression, where the cortisol system is upregulated. GI research, the patients commonly are found to have irritable bowel syndrome, they have abnormal gut flora, they have abnormal motility and abnormal H2S production or leaky gut syndrome. And there are the references with respect to that research for anyone who wishes to review that. The summary of the cardiovascular research, there are characteristic abnormalities of the EKGs, but this requires following them over time, and that's very difficult for a physician to do. There's decreased vagal activity, orthostatic intolerance. Absolutely every patient reports orthostatic intolerance. Decreased total blood volume, that's very reliable, but that's a hard test to do. It's not commercially available in the United States, so it would only be a research test. And most of the patients have low blood pressure and decreased stroke volume. You can sometimes measure that on a cardiac MRI because the patients will have diastolic dysfunction. And there are the references for any of those of you who want more details about that. Exercise research has really come to the forefront because if symptoms worsen with exercise, the science should be there to tell us why that is. So the symptoms get worse, heart rate's elevated, reduced work, reduced oxygen uptake, breathing irregularities, and prolonged recovery. So there has to be a reason why exercise worsens the symptoms, and later on under the new research, I'll show you some of the ideas about why that might be. And then summary of sleep research. We know that the sleep is very interrupted. It's not high quality sleep, and there's often alpha intrusion into delta sleep. And that means that during the time that you should be fully recovering and restoring yourself, you're actually having intrusions of being awoken. And the reasons for this aren't entirely clear, but they might be based on cytokine storm. So briefly, for physicians who want to go over the physical exam and laboratory workup that I recommend as standard procedure in diagnosing these patients. Again, it's one of exclusion. You can use any of these automated protocols now to tell you if the patient meets the definition or does not. You still do a thorough medical history and physical examination to rule out other causes of chronic fatigue syndrome. The physical examination, physicians are always frustrated by this because they say, I go through this whole exam and I don't find anything. Well, that's really the point. You don't want to miss somebody with a heart murmur or coronary disease or hypothyroidism or a malignancy. But there are a few things on the physical examination that can be found sometimes. Special attention to the musculoskeletal system, the CNS evaluation, cardiovascular, and the immune system. And again, the trigger point exam, which physicians know is part of the diagnostic criteria for fibromyalgia, should be done. Oftentimes these people also meet the criteria for fibromyalgia. They shouldn't have acute joint inflammation. If they do, there's usually something else going on. They may be hypermobile because there's associated genetic defect with Ehlers-Danlos and chronic fatigue syndrome, so you should look for that. Oftentimes a patient will tell you that they're hypermobile. They'll say, look, I can move my thumb way back to my wrist. So it's an easy question to ask people. And then we always document muscle strength. Again, on CNS exam, reflexes are important. The Romberg test is they'll often fail this, which is a test of balance. And then we evaluate cognitive symptoms, which can be done by formal testing, but it can also be done by some easy screening examinations. These patients will fail things like serial 7s. The rule is if they make 2 mistakes on serial 7s, they're out of the normal range. And for endocrine, of course, you want particular attention to the thyroid, adrenal, and pituitary systems. In the GI tract, you can find increased bowel sounds, abnormal bloating, tenderness. Again, on cardiac exam, it's exclusionary, but if you measure the blood pressure, they almost always have orthostatic intolerance. So I lie the patient flat for 3 minutes, then I sit them up, and their blood pressure oftentimes is lower, which is not a normal response. And then on the immune system, you can get tip-offs to what's going on. Some of the patients have sore throats. They have this unusual crimson crescent in the posterior pharynx. If you all go home and open your mouths and look, it's a purplish discoloration of the posterior pharynx. There's tender lymph nodes often, and sometimes this can be a clue to something else going on. A lymph node that's enlarged where it shouldn't be is 95% of the time an infection, 5% of the time a neoplasm. And then the findings of generalized malaise or specific findings such as splenomegaly. The laboratory workup, primary care doctors are very good at doing this. There's an automated evaluation that we all kind of use with anyone who complains about being sick. So those are screening diagnostics. There's some specific studies that are recommended. Then there's highly specific studies that are done for certain cases, functional studies, neuroimaging, and then things that are viewed as experimental and investigational. And again, screening diagnostic tests, we all do this. These are CBCs, chemistry panel, those kinds of things to look for any obvious abnormalities. They'll almost always be normal in these patients. And that sometimes does the patient a disservice because they have a disabling disease and the doctor told them all their tests were normal. Well, all their screening tests may have been normal. There's additional diagnostics that if you follow the algorithm for the diagnostic protocol, you have to do to ensure that people don't have other problems, such as cortisol, DHEA, thyroid. You don't want them to be iron deficient. And sometimes it's worth doing the narcolepsy panel. You will find somebody who is genetically suffering from narcolepsy. And when you treat that appropriately, all their chronic fatigue symptoms go away. So that's worth looking for. And then a rheumatological evaluation because of these overlap syndromes with particularly systemic lupus. There are some specific ME CFS studies that I encourage every patient to have because of the reliability and that these can be followed over time as well. Natural killer cell numbers and function is the most widely reported abnormality in the world by all the researchers who have looked at this. It's a test that should be done. It's reasonably priced and it's almost always abnormal. And in fact, it's strikingly abnormal. On a bad day, when I use myself as a control, my NK cell function is 90% of normal. These patients frequently are 1% or 2% or 3%. So it's a very useful test. Lymphonumeration panel, again, looking for cytotoxic T cells. Very interesting, but it's quite academic right now. It doesn't impact therapy particular. And then B and T cell function. We haven't said too much about B cells, but frequently these people do have low IgG subclasses 1 and 3, and that particular defect is associated with recurrent viral infections. And in the second section of talks, I'll talk about why that might be important. And then IgA and IgM, of course. So this natural killer cell, why am I so excited about this? Well, sharks only have natural killer cells. It's the only immune system they have. And it's a very primitive defense against tumors and viruses. So think about it. If you chronically don't have proper NK cell function, that puts you wide open for recurrent viral infections and the development of tumors. And one of the ways NK cells work is by producing porphyrin and granzyme A and B. And these can now be measured. So if you, in a test kit format, so if you don't have access to flow cytometry and NK cell functional assays, you can get some of the same information by measuring porphyrin and granzyme A and B. And in fact, if I have a patient with a normal NK cell function, I think twice about making the diagnosis of chronic fatigue syndrome. Then, of course, there's some highly specific ME CFS studies that have been shown to be useful and reproducible. They're harder to get. We're getting more esoteric now. You really have to be hooked up with a research center usually to get these. There are cytokine and chemokine abnormalities that I'll show during the research section that are reproducible and useful. RNA-seq is almost always elevated. Patients may have abnormal amino acid profile. And then there's some unusual organisms that you have to be alert to if people had certain exposures, maybe certain travel histories, maybe histories of recurrent herpes infections that would lead you to want to test for the herpes viruses and parvovirus. The reason that those can be important, and I'll show it to you, is those are treatable causes. If any physician here finds a case of parvovirus, voila, they just have a well patient. So it's worth looking for because you will find those people periodically. So cytokine and chemokine profiling, these are these abnormal signals that in a genetically susceptible host can result in what we now call cytokine storm. And there's a lot of researchers that believe that cytokine storm is causing most of your symptoms. These cytokines are very potent mediators of symptoms. And we have multiplex cytokine arrays available to us now. It's one of those techniques that's increased gradually. From you can measure 8 at a time to 16 at a time to 32 at a time. Now we can measure 64 at a time with just one test. And then they do analysis on this. And here's an analysis that says you can diagnose chronic fatigue syndrome with just 5 cytokines. And so then you can do the array, you can see if the profile fits. For those physicians who know anything about cytokines, these are the pro-inflammatory cytokines, the IL-6 and the IL-8 and the IL-1 beta. There's also a deficiency of IL-10. And that's kind of interesting because IL-10 turns off the immune system. So this gives credence to the theory that you have an upregulated immune system, and the vast majority of the patients do. The 2,5-A synthetase correlates well with symptoms and severity. It's hard to measure. Only a few laboratories offer commercially. For the physicians in the audience, this is the route by which interferon induces the antiviral pathway and results in viral lysis. We use it every day of our lives to get rid of viral infections, and it's very impaired in chronic fatigue syndrome. Functional studies, we do a sleep study if it's necessary, but a lot of times you don't have to do it. The patient tells you, I don't sleep, I'm awake all night, sleep doesn't help me. Nocturnal oxygen screen, this is something that's come up recently with the sleep apnea, and I suspect it's come up in Sweden as well as the US. You don't want to miss people who have classic sleep apnea because they can be treated and many of their symptoms go away, and perhaps they didn't actually have chronic fatigue syndrome. In the US now we can mail them an overnight oximeter. They hook it up themselves. You get a report the next day in the mail. This is all done by Wi-Fi, and you can see if the patient became hypoxic during the night. And it's very easily done, and you will find some people. I do encourage exercise tolerance testing with expired gas exchange for the reasons I said. If a big part of this disease is post-exertional malaise, you should be able to measure that. I showed you that we can. Many, many parameters, and it's reproducible. When you institute a therapy, the patient's treadmill performance improves. We do use neuropsychometric testing with some screening testing, and a simple thing to do for physicians is an SF-36, because this is standardized around the world. It's very easy for the patients to answer these questions. It's automatically scored, And you can do it on every office visit if you want to, and you can see how your patient's progressing. It's a functional scale, and all of these patients have marked abnormalities of physical and mental functioning on this 36-question test. So expired gas exchange, there's a lot in the literature now about doing 2 tests. And the reason about doing 2 tests, doing day 1 and then day 2, is it exacerbates or exaggerates the post-exertional malaise. You'll see here controls versus patients. Their baseline study is abnormal. So for many of my patients, their baseline study is abnormal, low VO2 max, resting tachycardia, etc. I don't need to go on to the second test. But if you do go on to the second test, you find a profound difference between the patients and the controls. And the 2-day test really is a stressor on patients. And as you'll see a bit later, we know now that we're doing our immunological studies on day 2 as well, when the patient has more symptoms. And there's characteristic abnormalities. There's many, many publications that were in the references about exercise testing. So neuroimaging can be really, really helpful in the patients who have neurocognitive complaints. MRI scans can be abnormal, and I'll show you those. SPECT scans can be even more useful. Those measure blood flow to the brain, and PET scans measure function. The 3 together give you a really nice measurement of what's going on neurocognitively in these patients in an objective way. Here's an MRI scan on the left showing these white lesions that are somewhat similar to those found in MS, but they're not identical. And then the SPECT scans on the right-hand side showing regional hypoperfusion. Those are areas of your brain that are not perfused. And the reason for this isn't clear, but there's a good correlation with cognitive dysfunction. So for some reason, maybe in a protective way, maybe by cytokines, we have decreased perfusion. There's a number of spinal fluid studies coming out soon, and I'll share those with you later that hope to look at the mechanism of action there. Sometimes in some patients you want to do a lumbar puncture to measure their spinal fluid to see if they have MS or if they have an acute encephalitis or mesial temporal sclerosis or something treatable. 24-hour blood pressure monitor can document the low blood pressures. Sometimes patients in the office will have normal blood pressures, but at home it'll be very low. Holter monitoring, I said, can be useful because you see these abnormalities in the T waves, but it's not necessary for the diagnosis. And then there's those areas that I call experimental and investigational. These all have a reason, but they're quite sophisticated. Oftentimes insurances won't reimburse for them. One of them is a gamma T cell clonal rearrangement, and the reason this is important is that's a regulatory abnormality of the gamma cell. And in all my patients who have developed malignancies related to their chronic fatigue, they've all had a gamma T cell clonal rearrangement first. So it's predictive. And then there's these exciting things that I'll mention briefly later, the DNA arrays, the messenger RNA arrays, and the viral arrays and human pathogen arrays. And these 3 latest points are going to be the answer, I think, to the real pathophysiology and how we should approach chronic fatigue syndrome. Finally, we've reached the point with rapid throughput where these can be done fairly cheaply, fairly quickly, and fairly reliably. So the future is ours as far as that goes. For those of you who know about this, DNA is a genetic predisposition. They are looking for SNPs. Those are isolated abnormalities of your gene that may give us an idea of why you are predisposed to develop this disease. Messenger RNA is what's actively going on in your body, and I'll show you some examples later about the utility of those studies. And then, of course, viral array and human pathogen arrays are now so sophisticated that they can very quickly tell you what organism you're infected by. And again, gamma T cell clonal rearrangements, I use that to screen for these people that are at risk for developing neoplasms. Here's an example of this. I won't go into this gel, but these are 7 patients who had gamma T cell clonal rearrangements. through screening, and 5 of those have developed lymphomas. So for those of us who do this work full time, that's a test worth doing and looking at. So I make a point about making a positive diagnosis. This is something that every physician can do. You can make a positive diagnosis of ME/CFS if they meet the diagnostic criteria, if they don't have the exclusionary criteria, and they have some supporting laboratory abnormalities. In the United States, they require only one supporting laboratory abnormality. So the one that I always use is low NK cell function, but you could use any of the others that have been out there. And then always be aware of not classifying somebody as idiopathic chronic fatigue, because it doesn't mean anything. It's a dead-end diagnosis. New symptoms, I always have to be aware of the fact that patients develop new things, other medical problems, other psychosocial problems, and things that need to be investigated. I think one of the worst things a physician can do is say, oh yes, you've got chronic fatigue syndrome, I'll see you back in 2 years. That just is not helpful to the patients or the physicians. Okay, so that's the conclusion of part 1. Are there any questions from anybody?
I can make the question from here, and you can just repeat it. It's about the exercise test. What exercise level do you have to reach for the test to work, and how do you measure that level to protect so you don't harm the patient with too much exercise? Like, would you accept the pulse for 120 pulses per second?
What the standard protocol is, and I always exercise all the patients to anaerobic threshold, because then we know that that's a maximum test, which is an RER of 1.1, and all these machines do that automatically, and they tell you when you're there. What you have to be careful of is that in these sick, disabled people, they may reach that in 30 seconds or 45 seconds. So if you're ordering your exercise tolerance test in a sports medicine clinic, which is very common, and I would suspect would happen here, the technician, they've fallen off the treadmill or the bicycle before they're even warmed up. So you have to educate your exercise physiologist in what you're looking for. And it's really it happens automatically, because they'll say, wow, this person exercised 55 seconds and they're anaerobic already. And that's exactly what we're looking at. And if you do it safely, patients do have a relapse of symptoms, but they are so reassured of their abnormality that I think it's useful when you document how impaired they are and how low their VO2 max is. For example, a very typical VO2 max in these patients is sitting right around 20 milliliters per kilogram per minute. And that's presumptive disability in the United States. You don't even have to prove what their disease is. If they're that low, they're disabled. So, and it's never seen in deconditioning. So it's really, really good test, and I encourage everybody to do it and physicians to order it. It's readily available most at these sports labs and things like that, and it gives you a real idea how sick and how disabled your patient is. It also improves as the patient improves, so it gives you a nice measurement. And it's never, this level of profound disability is never seen in deconditioning. Never seen in somebody who's just a couch potato, etc. And you know, the norms for exercise testing are age and sex corrected. So you're not being compared to a young athlete.
In your thyroid panel, do you check for reverse T3?
Yes. Always.
The neuroimaging, how specific are those little white dots which are seen at MRI? About 10% of normal people have them also, is that so?
That's absolutely true, especially in the older populations. But in a younger population, somebody under 40, they're never seen normally.
Den sista, sen tar vi fikapaus.
What is the reason for the maximal VO2 falling on day 2? Is it peripheral limitation or cardiac pulmonary limitation, or what is it? It's difficult to understand.
Yeah, we queried that for a long time because you will do echocardiograms on these people and they do not have diastolic dysfunction, they don't have inability to pump, they don't have particular heart rate limitations. So it must be a mitochondrial defect, and what the lights at the University of Utah has shown now is an aberrant enzyme signaling system to the muscle. It's really fascinating work. And I do have a slide about that later.
Right, I think we have to take a break now. Thank you for now.